used optimized diagnostic tests to diagnose Mullerian anomalies. Those using either 3D transvaginal ultrasound, combination of laparoscopy and hysterosalpingography, MRI, or sonohysterography. And they found that the prevalence of Mullerian abnormalities by these optimized tests are about 5% in unselected population, 8% in infertile women, about 13% in those with a history of miscarriage, and 24% in those with a history of miscarriage and infertility. So as you can see, as the obstetric performance of the patient became worse, the prevalence of Mullerian abnormalities apparently were found to increase in this population. And this is the breakdown of the kind of anomalies they found. You can see here in the first column, or the first row, you can see the incidence of arcuate users. They were more prevalent in low-risk women, i.e. women who have no reproductive problems. The incidence was about 3.9% compared to those with the poorest reproductive performance, which was 2.9%, those with miscarriage and infertility. The Mullerian anomaly that resulted in the worst reproductive performance was the septate or partial septate users, which was found in only about 2% of low-risk women and up to 15% in patients with poor reproductive performance, such as miscarriage and infertility. The other Mullerian anomalies were less prevalent in the general population and were, of course, more common in those in patients with miscarriage and infertility. This is just a schematic diagram to remind you of the embryology of how the uterus and the female reproductive system is formed. You can see that is formed from two paramesonephric or Mullerian ducts that fuse together, and as they fuse from below upwards, they form the upper two-thirds of the vagina, the cervix, the body of the uterus, and they remain unfused in the upper part to form the fallopian tubes. So you can infer the possible abnormalities. One is that there is complete failure of formation of the paramesonephric or Mullerian ducts, resulting in either Mullerian agenesis or unilateral failure resulting in a unicornate uterus. There is a fusion defect in which the two paramesonephric Mullerian ducts don't fuse together, either completely resulting in a didactic uterus or partially resulting in a bicornate uterus, or a resorption defect in which the septum in between fails to become resorbed or reabsorbed, resulting in either a septate or partial septate uterus or small indentation at the fundus, resulting in what is known or previously known as an arcuate uterus. So what ultrasound modalities can we use to help us diagnose these Mullerian anomalies? The first thing, which is considered to be a screening test, is the usual two-dimensional transvaginal ultrasound, and you can use your usual 2D vaginal probe to suspect that the patient has a Mullerian abnormality by scanning in the two usual planes, the sagittal and the axial plane, using the planning movement and the rocking movement. You can see here in the sagittal plane, as we move the probe from side to side, you can see that the endometrium is continuous all through the scan and is extending all the way up to the fundus throughout the whole scan. And when we move to the axial scan, from below upwards, you can see that from the cervix down, you can see the endometrium continuous all the way as a transverse strip extending all the way up to the fundus. So if you have these two images, you can probably infer that the patient does not have a Mullerian abnormality. You can see here another anomaly. This is the normal I just showed you, and you can see here this is a unicornate uterus, which was suspected by 2D ultrasound. And you can see as we move the probe in the sagittal plane that the endometrium is only present in a small portion. And when we rotate the probe to look at the axial plane, you can see that the endometrium, instead of ending in a transverse line like here, it ends in a circular region here on one side, because you only have one side of the endometrial cavity is formed. So it is not a normal triangular appearance, but rather a finger-like appearance. So you can also suspect a unicornate uterus using 2D ultrasound. This is another abnormality, much easier to suspect by 2D ultrasound. You can see when we do a sagittal scan, you can see the endometrium or the uterus appear and then disappear, and then another uterus appears. So obviously there are two separate uterine bodies, and when you look at the sagittal scan, you can see you have here two cervical canals and two separate horns separated by no myometrium at all. You can see some valve in the middle. So here you can suspect that the patient obviously has some sort of more severe are more common anomalies. This is septate uterus, while this is a bicoordinate uterus. You can see two endometrial cavities in the axial scan. You can see this triangular area. This represents this, this rectangular area. You can see this represents this rectangular area here. You can see there is myometrium intervening between the two endometrial areas. While here you can see that the two endometrial areas are separated from each other, and the myometrium ends here, and there is a hypoechoic area here, meaning that there is no myometrium right in the middle. So you can infer that this kind of anomaly, especially with the two endometrial strips very far from each other, is more likely to be a bicoordinate uterus, while this one, when the endometrial strips are close to each other with obvious intervening myometrium, this is more likely to be a septate uterus. Of course, for a definitive diagnosis, if you suspect something by 2D ultrasound, it's best to confirm your diagnosis by 3D ultrasound. And of course, as we all know, several studies have found that 3D ultrasound is just as good as MRI, which was previously considered to be as the gold standard for diagnosing of Müllerian anomalies. Now we depend on 3D ultrasound primarily because of its ability to show or demonstrate the coronal view of the uterus. As you can see here, this is an orthogonal plane, the three orthogonal planes of the uterus acquired by 3D ultrasound, and this is the 3D appearance of the coronal view of the uterus. You can see the outline of the myometrium, and you can see the triangular appearance of the endometrium. And this image, this is a comparative study between 3D ultrasound at the top and MRI at the bottom, and you can see the images are quite similar. For this reason, we have stopped using MRI unless we are not able to diagnose an anomaly by 3D ultrasound. Hence, we refer to do something more complex or more advanced and much more expensive, of course, such as MRI. So how do we do 3D ultrasound to diagnose Müllerian anomalies? Of course, like any ultrasound examination, the region of interest, and here, of course, it's the uterus, it has to occupy at least 70 to 75% of the image. The best time to do the examination is the mid-luteal or late luteal phase, so that you have a thick echogenic strip of endometrium in order to clearly be able to demarcate the outline of the endometrium and differentiate between the endometrium and the myometrium. And then, of course, we acquire the 3D volume, and we do some manipulation with the volume until we get the coronal view, as you can see here in the C plane. I personally prefer to use the C plane in the rendered see here that the uterus looks very strange, and only one fallopian tube was picked by hysterosalpingography. And you can see here that report coming with the patient with the hysterosalpingogram saying that this uterus is normal and there is a unilateral tubal obstruction, and this is the 3D ultrasound appearance. You can see that this was actually a septate uterus with a double cervix, and of course the error that was done here was that the individual doing the hysterosalpingogram injected the dye from one side only and was able only to see one side of the cavity and of course one tube. This is, I think, a very common appearance that we're all used to seeing. This is a mid-sagittal view of what looks like a normal uterus. You can see here, this is the outline of the uterus and this is the endometrium. But when you look at it in the axial view, you can see the image I showed you before. You can see that the endometrium looks a bit strange here. It looks circular, and there's another small circular structure with another hyperechogenic circular structure inside it, and this turned out to be my 3D ultrasound. This is a unicornate uterus here with an uncommunicating functioning horn next to it. So this, of course, we were able to diagnose it using 3D ultrasound, but we suspected it first by the 2D appearance. And this is the hysterosalpingography, sonography appearance of what you can see, the saline filling the cavity and the finger-like appearance of a unicornate uterus. This was another case, quite similar. You can see here, this is the unicornate uterus, and this is the non-communicating functioning horn. And next to it here, you can see that this is a very large structure, hypoechoic, and this is another structure here. So this was a non-communicating functioning horn, and of course next to it, because of the retrograde menstrual flow, the patient developed a hematosalpinx and an endometrioma in the adjacent ovary. This was another case of I think she was a 14-year-old girl that came complaining of severe dysmenorrhea at every month. And when we did the ultrasound, we find this very characteristic appearance of blood inside the vagina. This was hematocolpus, and of course the first thing we thought of was that this was an imperforate hymen, but the patient insisted that she had monthly menstrual flow. So when we looked closer, we found that actually this was a didelphic uterus. You can see here, this is the obstructed side, and this is the functioning side. So this was a didelphic uterus with right-sided vaginal obstruction, while the left side was normal and functioning with, this was the side that was resulting in normal menstruation, while the right side was the obstructed side. And you can see here, this is the transperineal image from transperineal ultrasound. You can see from the same patient, of course, because she was a virgin, you can see syphilis pubis, and you can see the bladder, and you can see the uterus here filled with blood, and the vagina, and you can see that the obstruction is very low down, close to the perineum, and sure enough, we were able to introduce a very narrow hysteroscope and do a very small incision in the vagina in order to allow escape of this blood and relieve the obstruction. This slide is just to remind you that Mullerian anomalies may also be associated with pregnancy. So when you're doing a scan for a very early pregnancy, don't forget to look at the appearance of the uterus. You'll be surprised because some patients may be pregnant in a uterus that has a Mullerian anomaly. As you can see in this case, this was, I think, 7 or 8 weeks, and you can see that this is a bicornuate uterus. Sometimes you get a patient that needs to do examination of uterus for Mullerian anomalies, and the patient is not at the optimal time in the menstrual cycle, in her late luteal phase, but rather in the early follicular phase. And for that, you can use sonohysterography, whereby you inject some saline in order to do a good delineation between the endometrium and the myometrium. And you can see here that the endometrial cavity is very clearly delineated using the saline rather than depending on the thick endometrium. And you can see we used it here. This patient had what looked like a septum, but we couldn't see it very clearly by the 3D ultrasound without saline. And you can see here after we injected saline on both sides, you can see the 2 cervical canals, and you can see the 2 cavities, one on either side. So we come to the last part about the classification of Mullerian anomalies. Unfortunately, there's as yet no universally accepted method for the classification. So why do we need to do classification? In order to have a clear and accurate definition, in order to enable clinicians to make diagnosis and differentiation between the subtate and the subseptate uterus, which have a very poor reproductive performance, as we have seen in the first slide, and other anomalies or things that we were previously known as anomalies, such as arcuate uterus, that now we know do not cause any reproductive problems, and more severe anomalies such as bicoordinate uterus, which we all now should not be managed surgically. And this differentiation is made by examining the coronal view of the uterus, looking at the external contour as well as looking at the shape of the cavity. The easiest way to do this, quite simply, is to look at the coronal view of the uterus taken by 3D ultrasound, and just to measure this angle here, you can see it. This angle, if it is less than 90 degrees, this is known as the indentation tip angle. If it is less than 90 degrees, then it is most probably a subseptate uterus. If it is larger than 90 degrees, then you can very safely say that it is not a subseptate uterus, but rather it could be an arcuate or even a normal uterus. The first classification that was introduced and common used, of course, we all remember it from our time as undergraduate students, is the classification used by the American Fertility Society, and it was very common because it was able to classify most of the uterine anomalies, but it had several drawbacks because it doesn't classify other anomalies such as those involving the cervix and the vagina, and of course it failed to differentiate between the uterus and the septate uterus. Arcuate uterus and the partial septate uterus. So sometimes it is difficult to use this classification. We want to know if the uterus we're looking at is a septate or a arcuate uterus. Using this classification, there are no clear delineations or cutoffs to differentiate between the two. Another drawback is this sub-classification here, the classification in group 1. It included a large number of unrelated anomalies, some of them with severe clinical implications, and many of them requiring surgical interventions with very, very poor outcomes. So it was not a very, very useful classification when we used to apply it for the treatment of surgical correction of these obstructions. This is why the SGH group decided to perform or to do their own classification system, and they used the Kanuta, which is known as the Congenital Uterine Anomalies Group, and they used the identify procedure in order, which was a sort of a questionnaire, anonymous questionnaire, in order to ask a large number of experts about what they thought were uterine anomalies, or what they thought was the classification of uterine anomalies, and they classified the anomalies depending on their ultrasound or their physical appearance rather than their embryological origin. And the most important factor in this classification is they based it mainly on proportions rather than actual centimeter measurements. And you can see their whole article online. It's freely available, the SGH classification system. And they used, of course, U4 definition of uterine anomalies, C for the cervix and B for the vagina. You can see the different anomalies. And they managed to include a lot of anomalies. Most of the anomalies were included. And you can see here, this is also a slide from the article. You can see the U0, which is the normal uterus, C1 is the dysmorphic U2, which is the partial septate, etc. And the most important for us is the differentiation between a normal uterus, septate, and the bicoordinate uterus. And you can see that they classified a subseptate uterus based on the proportion of endometrial or indentation of the endometrium. So if you have an indentation that is more than 50% of the whole myometrial thickness, then this is considered to be a partial septate uterus. If it is less than 50%, then it is considered to be a normal uterus. Of course, the danger of that is if you have this whole length to be about 1.5 centimeters, then if this indentation is about 8 millimeters, then this would be considered to be a partial septate uterus and thus amenable to surgical correction. So you'll have a very small fundal indentation, about 8 millimeters, and the patient will be classified as having a partial septate uterus. And of course, using their classification system, this is, if we use the previous classification, the American Fertility septate uterus than when they applied the American Fertility Society classification on the same uterus. You can see here from the slide from their article, all the uteri in this slide were considered to be partial septate uterus using the Esri-Edge classification system, while here you can see that the top two rows are actually considered to be normal if we use the American Fertility Society or American Society for Reproductive Medicine classification. Here you can see that the fundal indentation is less than 1 centimeter. Here you can see that it is between 1 and 1.5 centimeters, and here you can see it is more than 1.5 centimeters. So if you apply the Esri-Edge classification, all these patients would require surgical correction if they have poor reproductive performance. But if you use the ASRM classification, only those in the last row are those that truly have any meaningful anatomical problems that may require a surgical correction. Of course, this same group, the Ludwig group, they formed another classification system called the congenital uterine malformation group, or Q, and they also sent a lot of coronal images to a large number of experts. Can I have the 5 more minutes? This is the last classification, the SRM classification. I think this is the one we're all using now. I just wanted to show you this last slide, and you can see here that in this classification system, the SRM classification, you can see that this is considered to be a normal uterus, where you have a fundal indentation that is less than 1 centimeter and an angle of more than 90 degrees. A septate uterus is one that has a septum that is more than 1 centimeter in length, and the angle is less than 90 degrees, and the bicoordinate uterus is one that has a fundal depth that is more than 1 centimeter. You can see the ASRM classification. This looks like a normal uterus. You can see the top of the fundus, it is normal, and you can see here that this fundal indentation is very broad and very shallow, and this is less than 1 centimeter. This is a partial septum. You can see that there's no clefting at the top, there's a single unified fundus, and the fundal indentation, it is more than 1 centimeter, and the angle is less than 90 degrees, and here you can see this is a bicoordinate uterus with a fundal cleft that is more than 1 centimeter. This was a similar article that reached the same conclusion that we conducted in our department, and you can see that we reached the same conclusion that if you have an indentation that is more than 12 millimeters, and an indentation tip angle that is less than 90 degrees or 88.9 degrees, then this is more likely to be a subseptate uterus than an acute uterus. And these are images from our study. You can see the correlation between the 3D ultrasound and MRI. They look very similar. The top are subseptate uteri, and the bottom are arcuate uteri. But if you look at the images without looking at the measurement, you can see that they look pretty similar. So I don't think the reproductive performance of these two patients will be quite different, even though the measurements are slightly dissimilar. So what should we do if we diagnose a patient with subseptate or septate uterus? You can see from the recurrent pregnancy loss, this is a bulletin issued by Esri quite recently, and you can see that from their article or from their guideline that patients with a subseptate uterus with poor reproductive performance may benefit from surgical correction, but it is not yet 100% certain. And you can see that other Mullerian anomalies, of course, such as bicoordinate uterus and other anomalies, should not be managed surgically. Finally, this is a very important article which asks the question, does cystoscopic resection of uterine septum improve reproductive outcome? This was systematic review and meta-analysis, and they found from their article that patients that have underwent surgical correction of subseptate uterus if they had a Mullerian anomaly and they had poor reproductive performance, fared no better than patients that were managed conservatively. They both had similar live birth rates and recurrent pregnancy rates. So why is that? One answer is that not all subseptate uteri are the same. You can see that this is what looks like what we consider to be a normal uterus with a very well formed subendometrial and myometrial layer. This is also a partial septate uterus. You can see that this myometrial area is very well formed with good subendometrial blood flow, while here you have a septum, which usually have a much worse prognosis. So if you have a complete septum, then metroplasty may be beneficial. If you have a partial septate uterus, then metroplasty may or may not be of benefit for the patient. Finally, I just want to show you this patient that came to me complaining of hypomenorrhea. She had polycystic ovarian infertility, and her doctor previously diagnosed her as having a small septum, and he did a resection for her, and the operation ended in a disaster with dense intrauterine synecia. You can see this part here. This is saline that we injected in order to help to delineate the cavity. You can see this part here, which was completely destroyed because of the intrauterine adhesion. So I just want to, my final note is that try and be very cautious with patients with Mullerian anomalies. Don't rush to do a hysteroscopic resection unless you really, really have to. Only do it if you're an experienced hysteroscopist, not a novice that does one or two operations once or twice annually. Thank you very much.
Thank you, Professor Sharif. I really enjoyed, and I'm sure everyone here has enjoyed your lecture. It's full of cases, clinical cases, full of tips. Thank you very much. Any questions? We have 3 minutes for questions.
It's an honor to introduce my dear professor, Dr. Daniel Hay, the pioneer of ultrasound and the head of ultrasound unit at the university. Her lecture, challenges in the diagnosis and the management of pregnancies near the utero-tubal junction. As we use it to enjoy Dr. Damia lectures, and we hope this day we will enjoy more.
Okay, thank you, Professor Hand, for the introduction. I'm going to talk about the challenges in the diagnosis and management of pregnancies near the utero-tubal junction. We have to know that eccentric pregnancies includes interstitial, angular, cornual, and pregnancy in an anomalous uterus. However, it's crucial to differentiate between them because they are separate entities with completely different behavior, management, and outcome. So the terminology has been used interchangeably, and we are confused. So we need to standardize the terminology and to set critical diagnostic criteria in order to allow for appropriate management. Several papers have tackled this problem, and recently the Issue Working Group on Ectopic Pregnancy, they have provided in an elegant publication 7 consensus recommendations on how to describe normal cycle and different types of ectopic pregnancy in order to reduce the risk of misdiagnosis and inappropriate management. First of all, I will start with the interstitial ectopic pregnancy, which is a gestation that implants within the proximal part of the tube as it courses through the myometrium in the cornual region of the uterus. So how can we see it in ultrasound? The ultrasound criteria includes an eccentrically located gestational sac. It's within the tube, within the myometrium at the region of the fundus. So we have to be sure that it is separate from the uterine cavity by intervening myometrium, and it should be at least surrounded by a thin layer of myometrial mantle, and this is how we will differentiate it from ethnic tubal pregnancy. The cavity should be empty unless the cavity should be empty unless in cases of heterotopic pregnancy where we have a sac inside and the other one is small and confined to the tube, and it was even missed by laparoscopy. The key feature is the key feature is the interstitial line sign, which is the thin echogenic line that extends from the lateral angle of the cavity through the myometrium till it reaches the gestational sac. It represents, as you can see here, the proximal part of the tube that is not occupied by the ectopic gestational sac, and it increases sensitivity to 80%, and it is 98% specific. I'm sorry, فيها فيديوهات مش شغالة. However, the interstitial line sign is based on the sac size, and the growing sac may spread the the infancy, you know, it's dependent. As you can see, sometimes the growing gestational sac expanded, spread medially, so it will occupy the whole tube, so you can see the interstitial line sign, and even it may abut the endometrium line and even protrude in the upper lateral angle, and this is what is called as partial interstitial pregnancy. And as you can see here, it spotted the tube and it starts bulging into the upper lateral corner, and it's really difficult to differentiate it from angular pregnancy. More common, the growing gestational sac that is implanted in the interstitial part of the tube will grow laterally into the ethmic part of the tube, so it will produce a bulge on the outer serosal layer of surface of the fundus. Because of the distensibility of the myometrium, because it is proximate to high vascularity, it tends to grow larger, as you can see, and presentation may be delayed till 7 or 12 weeks. So in a study of 36 cases, 40% of the cases were misdiagnosed as intrauterine pregnancy, leading to rupture in 40% of the cases, and eventually mortality is highest in this type of ectopic pregnancy because of the increased vascularity in the area, and it's about 2.5% that accounts for 20% of all deaths attributed to the ectopic pregnancy. When 2D is inconclusive, we can use 3D ultrasound because it offers better outlining of the cavity from the surrounding myometrium. As you can see here, a thin layer of myometrium between the cavity and between the gestational sac. We need to differentiate it from ethnic tubal ectopic pregnancy. It's just, you know, it's very near to it's adherent to the uterus, or it's very proximate to the uterus, but it's not surrounded by a myometrium. And here, the 3D ultrasound can clearly delineate the interstitial part of the tube, and also we have to differentiate it from cornual fibra. However, the diagnosis is not always that easy. As you can see in this ICSI pregnancy, there is a sac-like structure there, and it was misdiagnosed as a gestational sac, but actually it's not. It was a collection of blood trickling from a gestational sac that is implanted in the ethnic part of the tube despite of tubal disconnection before the exit procedure. We have to differentiate between two important entities because not all eccentric gestational sac will turn out to be interstitial. We have to know that in interstitial ectopic, it is within the uterus, but it is outside the cavity. As you can see here, it's outside the cavity, while in angular pregnancy, the gestational sac implants in the cavity, but at the lateral angle, at its lateral angle. And it's very important to differentiate between these two entities because although they are only a few millimeters away, but they have very disparate outcomes. So a correct diagnosis is very useful in deciding the management, whether we're going to do a surgery, laparoscopy, craniotomy, craniostomy, or we're going to for conservative management. Of course, early diagnosis allows for more conservative management, where methotrexate has proved successful in 80% of the cases. As you can see, this patient, she received 2 doses of methotrexate, and the beta HCG was declining rapidly. But we need to know that the mass may persist, as you can see, may persist for up to 6 months. Okay, it takes time to resolve, so this shouldn't be considered as treatment failure. Okay, surgical management is necessary in advanced cases if the patient is complaining of pain, there are signs of hemoperitonea, or it's so advanced, as you can see, with protrusion of the sac, more than 50% out of the mantle, and we have to know that, of course, coronary section carries the risk of significant bleeding and tubal occlusion, in addition to the long-term risk of rupture in subsequent pregnancies. Because of its proximity to the high blood supply in this area, okay, there is a tendency to do AV malformation because of the abundant vascularity, and in these cases, selective uterine artery embolization will be very helpful. So, what about cornual pregnancy? We need to know that cornual pregnancy is just a descriptive term. It's just to describe a bulge or a massive fat on the outer contour at the cornual region. That's why it applies to many conditions, interstitial to angular. Okay, so that's why interstitial sometimes is mistakenly referred to as a cornual pregnancy. But cornual pregnancy is just a description of a protrusion on the outer contour of the cornual region. Some researchers reserve that term cornual pregnancy to pregnancy in one cornea of a bicornuate uterus or in a one-half ossificate uterus, but it's, as you can see, it's anatomically incorrect and confusing, leading to inappropriate management, and it was suggested to be abandoned. The Royal College of Obstetrics and Gynecology reserved the term cornual pregnancy to only the pregnancy in a rudimentary horn of unicornuate uterus. So, with strict diagnostic criteria that the main uterine body should be unicornuate with a single interstitial tube, that the ectopic mass should be completely surrounded by myometrium. This is differentiated from tubal ectopic, and it's separate from the uterus. This is how to differentiate it from the interstitial ectopic pregnancy, and it's only adjoined to the uterus by only a pedicle. We have to make sure that it is not continuous with the cervix in order to differentiate it from pregnancy in a septate uterus or pregnancy in a bicornuate uterus, as you can see. So the issue working group in ectopic pregnancy has noted that the term cornual pregnancy has been applied to so many conditions: pregnancy in bicornuate uterus, in septate, in whatever, in interstitial, in angular pregnancy, and they suggested that the term cornual pregnancy should be abandoned, and for rudimentary horn ectopic pregnancy is to be more descriptive of the condition, to replace the term suggested by the Royal College as a cornual pregnancy. We must use a rudimentary horn ectopic pregnancy has been described maybe 100 years ago by Howard Kelly as an implantation of the embryo in the cavity, but near the lateral angle of or near the uterotubal junction. Angular pregnancy again has been confused with interstitial pregnancy, and Johnson and Elliot has set criteria for its diagnosis that was based on the patient symptom, the patient symptomatic with asymmetric enlargement of the uterus, or during surgery, laparoscopy, or whatever, you notice that there is a lateral bulge on the outer contour with lateral displacement of the round ligament, or after delivery, there is a retention of the placenta. So a did review of 85 cases, over 85 cases collected over 80 years. The angular pregnancy love birth rate was 25%, abortion spontaneous 18%, while therapeutic, because the patient were afraid of its complications, they went for therapeutic abortion 18%, with a risk of uterine rupture and even death. So they were considered as high risk of pregnancy. Okay, but this or critical appraisal of this study or review that they collected cases over a very long period from 1934 till to 2014. So pulling the result, we have introduced bias because there is always a doubt that some of the cases that were diagnosed as angular actually were interstitial. They included only symptomatic patients, so asymptomatic patients may go under diagnosed. This will may lead to artificial high proportion of bad outcome. So it is a highly risk condition. Nowadays, of course, the ultrasound, there has been a set of ultrasound criteria that allow for early diagnosis of angular pregnancy, that it is eccentrically located at the lateral angle of the uterine cavity of non-anomalous uterus, and most important is it's not surrounded by myometrium. This is to differentiate it from the interstitial. It's all around surrounded by the endometrium with wide communication between the gestational sac and the cavity with no intervening myometrium, and these criteria allow for early diagnosis in symptomatic and asymptomatic patient, and clearly delineated from interstitial ectopic. The problem with angular pregnancy that it is a poorly defined clinical entity. You can see this image, and I cannot, there is no anatomic boundary where I can see this is an angular and this is a normal. It's not very clear distinction where is the angular pregnancy or the anatomic site of angular pregnancy. Okay, so it's anatomically incorrect term, and it was suggested to be replaced by eccentric pregnancy. And it makes sense that the nearer the gestational sac implanted to the uterotubal junction, the more the liability of having a protrusion or a bulge on the outer contour of the uterus. So is it clinically relevant? Because it was suggested, because it was proposed that it is a high risk of pregnancy, it's recommended to do a sequential ultrasound to see if it has moved to a more centric location, as you can see, and to ensure continued viability because it has been associated with miscarriage. As you can see, most cases they move to more centric location, Okay, and you see here the placenta already, and the baby moved centrally with a full-term delivery. Some of the cases may persist as angular pregnancy on the first follow-up and on the second follow-up, and pregnancy loss was detected. And interestingly, the same patient, she got pregnant a year later in the same location with the same outcome. So to answer the question, a colleague in Canada, they followed up 42 cases prospectively, to see what is the natural history, what is going to come. And they see that they reported that 20% every pregnancy loss. The preterm delivery were 18%, which is similar rate to that in general population. So there were no cases of fracture, deaths, abnormal placentation or hysterectomy. So they ligament. The head was impacted together with the placenta in this bulge, and it was delivered very hardly with one finger introduced through a constriction ring. Okay, so I think that further research is needed to propose a protocol of follow-up and management of cases diagnosed early in the first trimester. So in conclusion, interstitial angular pregnancy and regulatory horn are separate entities. Stop using the term coronary pregnancy. Standardized diagnostic criteria can possibly prevent potentially dangerous patient outcome. Further research is needed to define the outcome and associated risk of eccentric pregnancy. And thank you very much.
Thank you very much, Dr. Daria Usman, for this nice, excellent presentation. Any questions? Thank you very much. It gives me great pleasure to introduce the next speaker, Dr. Atif Fazari. Dr. Atif Fazari, he is a consultant gynecologist. He trained and worked in Sudan. He was a lecturer in the Khartoum University, and he was specialized and practicing in high-risk pregnancy and tumor surgery by laparoscopy and open surgery. He has extensive experience in fistula surgery. He moved from Sudan to Dubai, and he is the founder of Latifa Hospital Center of Excellence for Placenta Accreta Spectrum Management. He developed his own novel skills in placenta accreta spectrum surgical skills, and he launched Bazar Science and Dubai criteria for placenta accreta spectrum. And in that he published more than 50 scientific papers in peer-reviewed medical journals. The stage is yours, Dr. Atif. Welcome.
Okay, Dr. Juan. Good afternoon, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. It gives me a great pleasure to speak today for the second time after the placenta accreta spectrum discussion is morning time. And again, I would like to convey my thanks for Professor Muhammad Kamal and Professor Saad Gilani, as well Dr. Maaz for his effort done for this conference and make things easy, at least for me to reach here and to meet such experts like you. I would like to start my talk about cesarean scar pregnancy. I have no any conflict of interest and nothing to be disclosed. This talk is absolutely from my side. It's not sponsored by any institute. My scope in this session is to speak something about the pathogenesis, as well as the clinical presentations of these rare conditions. It looks like rare, but comes in increase, along with the diagnosis and the technique for the diagnosis, with some highlights about the treatment modalities. Scar pregnancy, it looks like 1 in 2,000 or 2,500, but a recent systemic review done in UK, maybe because number of deliveries is very slow, number of scars is low. It is 1.5 per 10,000 mortalities. A scar pregnancy or ectopic, the form of ectopic pregnancy, and it's seen regardless the number of previous scars. Strangely enough, not clear whether the number of the scar or the technique of the scar or the time interval between the previous scar, as we call fresh scar in the next pregnancy, or the subsequent number of scar affected the incidence of scar pregnancy ectopic. Similarly, if the patient has a previous scar and for some reason or other she got pregnant, for example, by the IVF or spontaneous pregnancy is the same number or occurrence of the scar pregnancy is the same. So it happens after IVF, it happens after spontaneous pregnancy, but there is a history of previous scar. For the parthenogenesis, yet nothing is well understood. All of them are hypotheses and postulated suggestions for that. But definitely there is implantation of the blastocyst in macrotubular space in the affected site of the previous scar might be clear in this. This site, accidental this morning, this is very affected part, and the layer which protects this spiral artery invasions, it is already lost in most of the cases, and seen also very clear the blastocyst is very more towards the cirrhosis or the remains of the myometrium. And as I said, maybe because of the short interval or because of the healing process. Anyhow, we have whatever the result, when the patient diagnosed should be classified in two. Either type 1 scar pregnancy ectopic or type 2. Type 1, it means endogenic. After implantation of the cyst of the gestational sac and the scar site, the growth, for some reason or others, is going towards the endometrial cavity. So it goes inside. And this type of cases has a potentially can continue the pregnancy, but at risk of severe hemorrhage, and the fate most probably is placenta accreta spectrum. I had a serious number of cases yet not published, maybe in the coming 2 months, around 8 cases of refusal termination of pregnancy, 8 cases of scar pregnancy. 4 of them refused termination of pregnancy, 4 of them agreed for termination of pregnancy. Out of those 4, we have 2 ended by hysterectomy because of massive bleeding, 1 ended by conservative management, and the other ended by leaving the placenta inside. All of them started as scar pregnancy. This is in favor of scar pregnancy's application of the placenta accreta spectrum, but still we do recommend a multicenter study from different sides of the world to give the result in the same way. So this type of endogenic is when there is a remain of the myometrium and the growth is going down. There is some maintenance of the myometrium, and this is endogenic when ended by more lateral placenta or placenta accreta spectrum. The other one is exogenic, when the growth is outside. In such conditions, she is at risk of rupture during pregnancy. Whatever the gestation age for that, was most probably between 6 weeks to 16 weeks, plus minus maybe average of 7.5 weeks. This type of most probably they are not continuous pregnancy up to the end. Maybe at the mid pregnancy they finished. And the growth is like this outside. And the remain is very minimum. This is a bladder, empty bladder after vaginal scan, very minimum space, and the growth is going upward with very bad vascularity. And this is an exogenic type of scar pregnancy. So our rules now, as I mentioned before in this morning, whenever you have an early pregnancy, the aim not only to confirm the pregnancy, inter-uterine or extra-uterine, ectopic or heterogenic pregnancy, or the ability of the pregnancy, of number of the embryo, I think it is better to concentrate on where it is history of scar pregnancy. As the patient have a history of scar, a history of previous scar, we need to look, is it a scar pregnancy? And areas possible, is it exogenic or endogenic? And then we have a very good sign, help us how to differentiate. The clinical presentation, most of the cases are asymptomatic and discovered incidentally. And if it is, maybe in some spots and can be considered as early pregnancy spots or threatened skin, rarely patient come with some pain. And even with pain or without pain, as far as they are stable, hemodynamic stable, we cannot exclude rupture of scar pregnancy. Clinical examination in stable women usually unremarkable. Nothing. No abdominal tenderness, no masses, no peripheral, nothing. And the gestation age for diagnosis between 6 or 5 weeks to 16 weeks, with average of 7.5 to 2.5 plus minus. The investigation for that, we used to take PTSD level, which might help in the follow-up if we opt for high management, and the ultrasound is a gold standard tool for the examinations with sensitivity, especially transvaginal, up to 85%, and under expert hand, maybe more than that. Or let us say the conscious-oriented examiner who sees the patient for the with such history, especially who interested in the abnormal precipitation, abnormal pregnancies. The ultrasound finding here, really empty uterus, I will tell you later in by the photos. Empty cervical canal exclude cervical pregnancy, and the gestation sac is located by somehow at the anterior aspect of the uterus. If we measure the uterus and the line of the endometrium at the mid, so most probably the anterior aspect, down or back to the bladder. Very thin myometrium wall is less than 5 centimeters. Give us suspicions whenever the sac is nearby for the scar of pregnancy, with very bad pericircular, vascularity on double. This table should go most of the clinics near the ultrasound scan or even the system. And here we can see this pregnancy, bladder may be here, the endometrial cavity, the lining is down here. So this is the endometrial cavity. So, excuse me. So this is the endometrial cavity. Here clearly demonstrated the myometrium line, very small myometrium, the sac high above anterior for the endometrial cavity, empty, closed with empty cervix. This is most probably ectopic scar pregnancy. Vascularity around that, always suspicious of ectopic scar pregnancy. And we have something called, all of you are quite sure you know it, crossover sign. Crossover sign, usually we have a line from the fundus or from the above side of the segmental view, from the endometrium down the internal os, and a perpendicular line from the reflection of the bladder towards the posterior triangle. At the cross side here, this is the side of our study, this is the side of the rest, and with the relations of the gestational sac, where is the gestational sac? From this cross point, this is called crossover sign, COS. Either to be a normal or crossover type 1 or type 2 minus or type 2 plus. So 4 grades or categorizations for crossover signs. One by one, this is definitions to come. This is the gestational sac. This is a line. This is this triangle side is the side of the scar, is defected myometrium, the black one, and the gestational sac of early pregnancy is implanted higher away. So this is a normal. This is a normal implantation, and we have nothing to worry about. But here we have the same line, down is perpendicular line. The whole or at least 2/3 of the sac occupy or cover hidden this triangular, the defect site. And this is clearly cross-sign 1, and this is scar pregnancy, no doubt. Okay, this is type 1. Then the cross sign plus 2, when 2/3 of the gestational sac is down, but still there is some remains here. So most probably 1 can go as exogenic and 2 maybe continue as endogenic, but still attached. And the other one is plus minus is still is attached, but nothing near or crossing. So all are really very simple, very easy. Just imagine the line and draw, and you can finalize which type of scan pregnancy you are dealing with. Furthermore, the magnetic resonance images might help, and especially the doubtful case, and give a good detailed characters of scar pregnancy localization, especially congenital malform or very bad problem for like myomictus cases, and the depth of myometrial invasions or involvements, and presence of the bladder involvement. Sometimes the bladder is there, especially previous surgeries. Coming to differential diagnosis of scar pregnancy, either spontaneous miscarriage or ongoing miscarriage, and rest is there. But when you apply Doppler for a dead miscarriage like that, there is no flow, and most probably in the midline, and associated with some features of miscarriage, like a pain and bleeding and so on. Okay? Especially if the patient followed regularly, maybe had a previous documented pregnancy site. Cervical ectopic pregnancy, it will be down, it will be completely empty, and the sac is below the internal os. But in scar ectopic pregnancy or cesarean scar ectopic pregnancy, the sac is above the internal os. This is very important in addition to the sliding signs, which is not here in the scar ectopic pregnancy. Because of time, I'm a little bit in hurry. Coming to the treatment, we have 3 options of treatment: either expectant management, or medical management, or surgical options. But no consensus which is better than other, because we have a list of requirements and criteria should be fulfilled for each of them, and factor might affect the option of management. Number 1, the type of ectopic scar pregnancy. Most probably is proved, especially by experts, it is exogenic, unlikely to successful. So the surgical option is advanced. Sometimes the gestational sac is advanced. So I doubt medical or expectant management can be an option for her. And sometimes maybe a very viable big baby or fetus, 11, 12 weeks active cardiac beat is not good for the medical treatment sometimes. And in the case of him instability, regardless the type of ectopic scar pregnancy, she's a candidate. She's a candidate for surgical options. As I mentioned, the size of the pregnancy and her fertility wish, because one of the surgical options of the treatment, like uterine artery embolizations, affect the endometrium health or well, and surgical option like hysterectomy sometimes with these options. And the little bit ECG, and the gestation is at advanced, presence of absence of cardiac fetal activity, and fertility wish, and availability of X, especially when we wish or we need to go for minimum invasive surgery like hysteroscope or sometimes laparoscope. If there is no incident, better come back for a laboratory, or at least refer the patient stay to a specific center. The success and communication between the surgical, expectant, and medical, we will see for the surgical management the best or less number of complications, although expected management has serious complications. Expected management, it means she continues the pregnancy most probably. So the success rate of expected management almost cervical has a high rate of success, almost 95 or even more, and with less rate of complication. And most probably the complication related to the scar pregnancy itself, unlike to the surgery, because usually, attempted by expert person. Okay? For example, like meningitis, infiltrations, and so on. Coming to expectant management. Expectant management, all in all, we need a proper counseling and detailed information and to be in hand for the couples, the husband and wife, and shared with doctors, the psychologists, or whatever. We need a counselor to convey the message and information for them in the right way. Because if she opts the expected management and she chooses that, it means she ends by placenta abrupta spectrum most probably. So she will take her life or the threatened life condition in her hands. And she will be signed for that and consented for that with very close, frequent follow-up and to see how much the endometrium is, or the myometrium being more and more thinner, and the affected adjacent organs are involved, like ureters, bladder, or whatever. So expected management might need intervention at some stage of pregnancy, especially the exogenic time. It might end by laparotomy at 20s, gestation age. Or we need a proper plan after good, optimizations of the neonatal outcome by magnesium sulfate or beta-mesazole or whatever for neurogenic protections and respiratory and surfactant. They should prevent the respiratory problem and to deliver the baby as early as far he or she passes the maturity, maybe 24 plus 28, according to the policy of the hospital, according to the facility of the unit and the adjacent service of the skills personnel, of the present skilled personnel for the management of placenta abrupta spectrum. So, expectant management, still there is some people choose that. The problem with expectant management, as I mentioned, severe bleeding, rupture at any times, and risk of hysterectomy along with severe invasions of the placenta. We have some, systemic review proved the outcome of the expected management of 70% live babies, and the rate of hysterectomy almost the same, 70%. For the medical treatment, we have two choices for the medical treatment: either methotrexate or other fetocidal treatment like lidocaine. We sedate the patients, counsel the patients, and directly, most probably, either systematic injection of methotrexate according to the body surface area, 50 milligram per meter square, or we can give direct methotrexate through the needle ultrasound guided to the heart, and it depends on the size, and most probably this direct injection risks the patient for rupture of that scar. It will be transvaginal or transabdominal. Anyhow, it depends on the experience, the patient choice, and the protocol of the hospital. Anyhow, methotrexate, as mentioned, can be directly or systematically along with the fulonic acid. For the other option of medical management, we have local fetocidal injections, most probably lidocaine for the cardiac beats, and like other fetocidal to kill the fetal cardiac activity, and selective fetocidal actions. This is very good in heterotropic pregnancy. We have heterotropic pregnancy outcome on IVF, very premium baby. The decision of termination of the normal baby is very serious outcome. Nobody can predict. So we can try this fetocidal to kill the scar pregnancy one and to kill the other. Because methotrexate systematically will not affect the normal baby. So we don't like to affect the normal baby. Lidocaine can do nothing for this almost lost baby, the scar pregnancy baby. Anyhow, all of them at risk of failure and become for surgical management, be very still and our backup is a uterine curettage. But there is some people not believing in uterine curettage because the mass anatomical wise by default is not in the way of curettage, it's in the roof. And this is clearly embryonic, like what I have on case can walk and you can trace the margin and the size, and you can see the blood or whatever, maybe perforation and so on. Remains of laparoscope is good. You can sometimes operate from 9 and above, especially with those or do some sort of vein resection for that affected site as a niche. And laparotomy is definitely the solution for that whenever we fail any one of them. Uterine artery embolization in selected patients because it's a sequel of uterine artery embolization and usually used with combination of others like methotrexate or curettage or hysteroscopic resections. Combination of treatment and choose one of them, whatever, potassium chloride, bucane, hysteroscope, whatsoever, it can be. And medical surgical, especially the difficult or failed one. So you can do a combination, especially with the history of recurrent scar ectopic pregnancy or non-case of scar niche and not treated or treated as well. This is very difficult sometimes to respond to one option or one modality of treatment. We have something called post-treatment follow-up. This slide is applicable only for the people who start the medical treatment. And here we need the baseline PTSD. We did it at the beginning, and in selected cases, along with Doppler and transvaginal study. Because, in spite of medical treatment you get, in spite of regressions of the size, still scar pregnancy is at risk of ruptures. And this is a big problem. So again, we will move back for the laboratory or surgery. Continuous fetal cardiac activity is not a good sign at all, so definitely go for the surgery. It means failure of medical treatment, and as I mentioned, the PTSD is very important here. Recurrence. Nobody can tell, and this individual cases. Again, loss of data, number of cases is not that few, but it can be. So we need to collaborate to see what the study is recurrent or not. But if the patient has the question here, a history of scar pregnancy, she can get a normal pregnancy without complications and continue. And the big question: are we going to give her trial for vaginal birth with this history of scar, not scar pregnancy, previous scar, and scar pregnancy, or we would like to go for an elective C-section? Debatable, depending on your decision and your case and the counseling. Because only affected side, especially if you are not treating that patient. It's still individual decisions, and the same best practice for the patient you can apply. Maybe also I recommend C-section. This is one of engineering pregnancy. The space is aware. Yolk sac coming definitely pregnancy positive. Okay? Positive pregnancy test. Space between the bladder, less than or more than 5 millimeters, is going in between. The others very clear, and you can see. Okay? Sorry. And we opt for her hysteroscopic resection. So hysteroscope, sorry for this artifact. This is the mass, and this is the endometrial cavity. I went by the hysteroscopic side to see the post posterior. This is the left side of the model. This is the right side of the endometrial cavity is very clean, and we did resections. This is the examination. After refining, this is the final look. This is normal. And we recheck again for some reason or other, maybe some cell. See, almost the same finding, and this is one of the cases can be managed by hysteroscope. We have one case, just mention something about the niche. This is urinary bladder. This is the light of hysteroscope from down, showing or shows the defective membranous side of the scar. This is scar niche. This is the anterior wall of the uterus, and we did wedge resections here, and we sutures the defect, and almost we are near to the cervix beneath to the urinary bladder. This is a niche repair. So if patient came with you with recurrent vaginal discharge and macroregia in between the spots, please, especially if she gave a history of cesarean section scar, regardless the number of the scar, please think for niche. Now it is a pathology of the last 20 years, but still it is not popular to be seen. Vaginal offensive vaginal discharge, macroregia, exposed between the cycle, and history of previous scar, without scar pregnancy, without other pregnancy, think of hysteroscopic examination, ultrasound examination before that, transvaginal, you will see small pocket, and you can go for simple repair. I think this is one of the things prevent scar pregnancy. We might help to decrease the number of the subsequent placenta abrupta spectrum in the futures. In conclusion, scar pregnancy is rare complication of previous scar and still diagnosis in between the patients. Implantation of the embryo at the site of the scar, giving endogenic or exogenic type, usually have some vaginal bleeding, but otherwise asymptomatic. Ultrasound with Doppler and transvaginal ultrasound is very important and sensitive for diagnosis, so it should be the primary diagnostic tool. And early diagnosis might help in the proper management after the pregnancy. This is one of my published paper on the medical treatment of severe scar pregnancy, and this is my reference. Thank you very much.
Thank you very much, for this excellent and informative presentation. Any question for Dr. Wahab? Okay, thank you.
Next speaker, Professor Rasha Kamil, Professor of Obstetrics and Gynae, Cairo University. She will present transperineal ultrasound in gynecology. Professor Rasha is a pioneer in the transperineal ultrasound, and we hope we will enjoy this lecture as usual. Every lecture for Professor Rasha is very interesting, and this topic is very interesting for us.
Hi, good afternoon, everybody. I would like to begin by thanking the organizing committee, Dr. Adman, for the organizing committee of the 16th ESOG International Symposium for inviting me to give this talk. I'd like to thank the Honorable Chairman for the kind introduction and for chairing the session. And I'd like to extend my greetings to my colleagues on the floor. I'll be giving an overview for the use of transperineal ultrasound in gynecology. Transperineal ultrasound has been introduced mainly for monitoring the progress of labor and other uses in labor and in the labor ward. Now it's been extended also for diagnosis in various gynecology problems and gynecological issues. I will just give an overview about the various applications. And the main application for transperineal ultrasound is in pelvic floor disorders. And as we know, pelvic floor disorders, the term pelvic floor disorders encompasses three main elements: stress urinary incontinence, pelvic organ prolapse, and fecal incontinence. And the ultrasound parameters that we look for in these three different
also note for the position of the bladder neck and its descent on the valsalva. For the pelvic organ prolapse, we also note the movement of pelvic organs below the reference line, especially on valsalva. And for fecal incontinence, we look for thinning and disruption of the internal and external anal sphincters. Of course, pelvic floor disorders are traceable to the birth, childbirth, or surgical trauma. The weak, torn, thin pelvic muscles, ligaments, and/or fascia will end in loss of pelvic support, pelvic organ mobility, and prolapse, which will give the symptoms of pelvic pain and pressure, which will give the symptoms of urinary incontinence, or retention, fecal incontinence, or retention and constipation. And we know that there are multiple factors for pelvic floor disorders, and it can affect multiple compartments of the pelvis, therefore giving multiple symptoms. There are risk factors, of course, for pelvic floor disorders: age, parity, history of pelvic surgery, problems with chronic increased abdominal pressure, ethnic and genetic factors. Also, all these affect the prevalence of pelvic floor disorders. The different modalities of imaging of pelvic disorders are transcranial ultrasound, whether by 2D or by 3D and 4D ultrasound, endoanal sonography for visualization of the external anal sphincter. We can use MRI, we can use voiding cystourethropy for urinary symptoms or urinary system disorders. We can use fluoroscopic echocardiography for rectal problems, and we can use colonic transit studies as well. So why do we use transcranial ultrasound out of all these different modalities? Transcranial ultrasound does not have the hazards of ionizing irradiation. It offers us the dynamic assessment. With ultrasound, we can assess the pelvic and the pelvic floor at rest, upon contraction, upon valsalva. There's no bowel distortion in transcranial ultrasound. Transcranial ultrasound, as all modalities of ultrasound, is highly reproducible and highly objective. There's no high subjectivity in ultrasound as in the clinical examination. Ultrasounds are widely available in all hospitals and all units. The skills acquired and the skills needed to perform an adequate ultrasound are easy to develop. And of course, ultrasound is quite acceptable to most of the patients and to examiners as well. So how do we conduct the transcranial ultrasound? We have to prepare the patient, empty the bladder. The bowel also has to be empty. We have to prepare the probe we're going to use, and the patient's position also is important. Usually we scan in the supine position or the modified lithotomy position. In rare instances, we might scan in the standing position when we want to use the gravity to optimize prolapse development. So this is how we prepare the probe. We get the transducer, the abdominal transducer. We apply some gel to the footprint of the transducer. We cover it by a sterile shear cover, and then we apply gel on the external surface. And there are two applications for transcranial ultrasound: either vertical application, as we can see here, where we hold the probe vertically to the perineum. In this application, we get to see the pelvis in sagittal and in successive parasagittal views, or we can apply it horizontally, and we incline it upwards and downwards. And with this kind of application, we get to see the pelvis successively in axial views. So when do we do ultrasound, or when we do not do the transcranial ultrasound? The bladder, as I said, has to be empty. With a full bladder, we should not attempt to do transcranial ultrasound because the organs are going to be less mobile and it will interfere with assessing for the complete descent. Also, the same applies for full rectum, and also the full rectum will result in a poor transcranial ultrasound image due to the shadows that are going to be cast from the rectal contents, and also a full rectum will not properly descend on valsalva. So in these cases, we just defer the examination after we empty the bladder or empty the bowel. So this is how we orientate the image. When we apply the probe vertically, the landmark on the probe has to be pointing upwards, and we have to synchronize it with the image on the screen of the ultrasound. And these are the successive organs that are going to get displayed as soon as we start scanning. This is an illustrative demonstration, and this is the actual ultrasound image that we get. So from up downwards, first
structure on the left is the symphysis pubis. Then we get to see the urethra and the bladder. Then we get to see the vagina and urethra. Then, and the uterus. Then we get to see the anal canal and the rectum. And the last structure on the right-hand side is the pubal rectalis. Anatomically, pelvic floor disorders are classified into 3 compartments. The anterior compartment is the bladder and the urethra, middle compartment, uterus and the vagina, and the posterior compartment are the disorders of the rectum and the anus. Of course, this is a rather simplistic approach because usually it is a multi-compartmental disorder involving more than one compartment together. So when we want to assess for the pelvic floor strength, we usually use the mid-sagittal plane and we assess the pelvic floor muscles at rest, and upon contraction we ask the woman to contract and we ask the woman to push down or exert a maximum valsalva. When we ask her to contract, we should note cranioventral displacement, which means that actually the pelvic organs are going to be sucked upwards and towards the symphysis pubis, and the opposite will happen upon pushing down. I'm going to show you how we see this. This is when we ask the woman to contract. So this is the resting position. Please refer to this resting image. And then we ask the woman to contract, and as you can see here, upon contraction, the organs tend to be moved cranially and towards the symphysis pubis, ending in a reduction in the levator hiatus. This is what we call the levator hiatus, which is the plane of the minimum levator dimension. It extends between the symphysis pubis and the pubal rectalis. So this is at rest again. I'm going to show you again. And this is what happens when we ask the woman to contract. You can see that the distance here actually diminishes. And this is the levator hiatus, as illustrated here, just to show you how it actually decreases in size when we ask the woman to contract. On valsalva, actually the reverse should happen. As you can see here, the levator hiatus is expanding, the distance here widens, and the pelvic organs, instead of being sucked up anteriorly towards the symphysis pubis, they're actually pushed posteriorly towards the anal canal and the pubal rectalis. So these are how we assess that the pelvic floor muscles are intact, if she's properly contracting or if she's properly pushing down. So what happens when we have weak pelvic floor muscles? Here, upon contraction, we're asking the woman here to contract, and as you can see, nothing really happens to the distance between the symphysis pubis and the pubal rectalis, and the levator hiatus is not really affected, and the organs are not really moving because the pelvic floor muscles are very, very weak. And when we ask the same woman to push down, instead of the pelvic organs remaining in position, we end in high or an exaggerated prolapse of the organs, as we can see here. For stress urinary incontinence, on ultrasound, we get to visualize the retrovesical angle upon at rest and upon valsalva. And as we can see here, what happens with the retrovesical angle is that it gets widened. I'm going to play this again. This is the retrovesical angle, and when we ask the woman to push down, you can see here the angle. Actually, the urethra gets pushed outward, and the angle is obliterated and actually turns from an acute angle to an obtuse angle. Normally, this angle is between 90 to 120 degrees, of course, with individual variation. With stress urinary incontinence, when we measure the retrovesical angle, it can go up to 160 degrees. Also, we have what we call a rotation and descent of the urethra. The urethra is going to descend and it's going to rotate anteriorly on the symphysis pubis, as we can see here. This is also one of the hallmarks of stress urinary incontinence on ultrasound. And the third ultrasound parameter is actually the distance of the neck of the bladder as regards to the symphysis pubis, and when we ask the woman to push down, we can see that it is actually pushed outwards. So let us see how these parameters look on actual scan. This is the symphysis pubis and this is the pubal rectalis muscle, and we are asking the woman to push down. You can see marks of stress urinary incontinence. For the pelvic organ prolapse, we can actually quantify the extent of prolapse, we can measure it, and we have a point of reference, which is a line that is drawn between the inferior margin of the symphysis pubis, it's called the reference, and the puborectalis, it's called the reference line, and we take our views on the mid-sagittal plane, and we assess on this plane. This reference line extends here between the symphysis pubis and the puborectalis, and it corresponds to the pubo-coccygeal line on MRI. So when we ask the woman to push, we want to actually assess the pelvic organ prolapse. We ask the woman to push, and we note where the pelvic structures travel as regards to the reference line. As you can see here, the urinary bladder went far below the reference line, and also the rectal ampulla went far below the reference line. This is just to take you back to the normal situation. Here, this is a patient who is pushing, but as you can see, the neck of the bladder did not go beyond the symphysis pubis, and the rectal ampulla did not go beyond the reference line. So this is how a normal pelvic floor should look like upon pushing. When I say quantification, it's measurement, and this is one of the main advantages of ultrasound, is to measure the problem instead of having a subjective evaluation. So certain cutoff values have been proposed where we measure the extent of prolapse of the structure below the reference line, and for the rectocele, if it goes 15 millimeters beyond the reference line, this means that is of clinical significance. For the cystocele, or for the neck of the bladder, when it goes beyond 10 millimeters, the reference line, this means it is of clinical significance. This is a case of combined cystorectocele. Please, my pointer is showing. Please see the neck of the bladder and the ampulla of the rectum as it jets way below the reference line. And this is actually a very interesting case. This is three compartmental prolapse, which means this cystocele, rectocele, and uterine prolapse as well. This is the cervix and the uterus, and this is the urinary bladder, and this is the rectum. We all know the importance of the levator hiatus. It is the largest hiated portal in the body. It's traversed by the urethra, vagina, and anal rectum. So any abnormality in the levator hiatus will cause substantial disturbance of the function of these organs. So we can use the transperineal ultrasound to assess the levator hiatus by different methods. By 2D ultrasound, we can just measure the levator hiatus, which is the plane of minimal levator dimensions, again, as I said. And we measure the distance between the symphysis pubis and the puborectalis on a 2D regular ultrasound scan. most area is the corrugations of the anal mucosa. So this is a normal anal sphincter. And if we have a 3D, also it's important to take the volume and to apply the tomographic ultrasound imaging, which cuts the volume into successive slices to visualize the whole of the anal canal, because as we know, the anal canal has some depth, so it's not enough to see only one plane of the anal canal before we comment on the intactness of the external anal sphincter. And to diagnose obstetric anal sphincter injury, we have to visualize the defect in the external anal sphincter or the internal anal sphincter, sometimes both of them in three or more slices of the TUI of our volume. You can also see internal anal sphincter defects alone. This is usually seen in elderly patients, so it's not really obstetrically related and sometimes iatrogenic after hemorrhoidolysis. Other applications for transperineal ultrasound, we can use it for the post-operative assessment of prolapse and incontinence surgery. So we do the transperineal scanning before surgery and we do it after surgery and we compare. We can use it to assess the status of the bladder neck suspension procedures. We can use it for vulval and vaginal lesions, and we can use it also for aesthetic gynecology procedures, pre and post procedures. This is a very interesting case. We were scanning this patient. She did not even know that she had a vulval cyst, and this is a vulval cyst seen by transperineal ultrasound. Here is the volume of the cyst. This is another example of a vulval cyst, which is a Bartholin cyst here. This is an axial scan. This is the clitoris, the glands of the clitoris, and then as we go downwards, we start to visualize the Bartholin cyst. Anterior vaginal wall cyst can also be seen by transperineal ultrasound. In this case, this is a Gardner's duct cyst. We can visualize the cyst, exactly the anatomical site and the relations to the surroundings before we opt for excision or drainage. There are some limitations for transperineal ultrasound, of course. The limitations are the multi-compartmental disease. Sometimes pressure on the facial defect of one compartment can obscure the descent of this compartment. It is rather operator dependent. It has also something to do with the skills of the operator. There is a limited field of view. We are going to compare it to the MRI. And of course, the equipment variations. The higher the resolution of ultrasound, of course, the better the results and the higher reproducible the results is. Thank you very much.
Thank you, Dr. Rasha. It's really marvelous. Lots of cases and lots of things again. Any questions, Dr. Rasha? Yes.
In urogenital prolapse, I can see in urogenital prolapse, I can see the urethroceal cystocele. The question: what is the additional benefit of ultrasound for urogenital prolapse?
This is a very important question. The additional benefit of ultrasound is the benefit that we always acquire from ultrasound and a clinical examination. Ultrasound is very objective. If you are in doubt for something, you do the ultrasound, you measure what you see, it's very objective. زي ما دايما we always quote Galileo واحنا
Suha Farhan, obstetrician gynecologist, graduated from Cairo University in 1994, and worked 15 years as obstetrician and gynecology in Saudi Arabia. But now, for the last 8 years, I am working ultrasound application and marketing manager. Recently, for the last 3 years, with Skip company. Today, it will be my pleasure to introduce for you something new, which is artificial intelligence. And we all know that artificial intelligence is something now is applied in many fields. And in the medical fields also, artificial intelligence is doing something great to improve our efficiency and also to improve our workflow. Today, I'm going to talk to you about the clinical benefits of artificial intelligence in obstetric ultrasound. So how this artificial intelligence will magnify our OB-GYN scan efficiency? We have a new type of AI and a special application called SFetus4. SFetus4 is an obstetric screening assistant. And I will tell you all the importance of this application and what you can benefit from using such applications. Let us start with a brief introduction. You know, everyone knows ESOG, and we are today in the ESOG 16 symposium. So let me tell you something, that our SFetus4 is already based on the guideline of ESOG. And ESOG keeps improving and standardizing fetal screening, as all of us know, from 2010 until now. The ESOG Clinical Standard Committee develops practice guideline and consensus statement providing recommendation on how to improve and standardize medical care, which included 16 practice guidelines, 10 consensus statement, and translation in over 18 languages. So let us concentrate now about the practice guideline for the examination of the mid and third trimester. As all of us know, our fetal anomaly scan and the evaluation of the pregnancy usually done in the mid trimester. That's why this S-fetus is already based on these guidelines for the examination of the mid and third trimester. And during these guidelines, the most important are 7 points. The first one is the fetal biometry, as all of us know, and fetal well-being, which include biparietal head circumference, femur length, and also abdominal circumference. And the estimated fetal weight, amniotic fluid assessment, placental assessment, fetal movement, Doppler ultrasound, and multiple gestation. And the one which we need now is the anatomical survey, which is that is the one which is really important in our SFetus4, in addition to the fetal biometry. So in anatomical survey, the guidelines of the mid and third trimester include the evaluation of the head of the baby, the face, the neck, and the chest and the heart, and also evaluation of the abdomen, skeletal, placenta, umbilical cord, and genitalia. And each of these has its own segments which should be evaluated fully. Excuse me because I have some problem with the vocal cords, so my voice is maybe not that clear. So regarding the head, the cranium, we have the most important 3 planes: transcerebellar, transventricular, and transthalamic planes. And also we should evaluate in the head the nose and the lips, and also the profile of the baby, the orbits, and we have to also evaluate the umbilical cord insertion, because as we know from the clinical importance challenges that may affect our performance and our efficiency, including the increasing number of births, the long waiting line in hospitals, and sensitive doctor-patient relationship. Also, the repetitive strain injury for the doctor himself while doing ultrasound, and time-consuming and skill-intensive manual. That's why Somscape thought about using the artificial intelligence to solve some of these challenges. So, what is the importance or the why in the artificial intelligence? What we can benefit from using such technology? As you can see, artificial intelligence in ultrasound should deliver intelligence, accuracy, and efficiency. So, that's why, in order to get this, we need special programs and special time and feeding for the computer inside the machine. Like in the next slide, this is how they are developing the artificial intelligence in ultrasound. They already start by providing a lot of database for the big database for the patient, to give this database inside the brain of the machine, and then the machine, when we do scanning, try to do feature extraction. Using the memory it already collected through deep learning, and then after extracting the feature, the machine knows by itself what now we want to see. For example, if there is abdominal circumference on the screen of the ultrasound machine, the machine itself will know this is abdominal circumference. We don't have to tell her, please measure for me abdominal circumference automatically. The machine itself will recognize the abdominal circumference and will measure it automatically. So this is the idea of the artificial intelligence. So in artificial intelligence, using this S-fetus, you can see on the screen, this is the video, only one touch on the application called S-fetus, and the machine will start detecting different planes and examining the measurement automatically for each plane. you can watch what she is saying is already written.
Upgrading for 3 years. I achieved a breakthrough with a database expansion of over 1 million standard images. Through deep learning, I accelerate the image processing power and provide a real-time diagnostic assistance with optimized performance. Iterating and improving over time, I expand my assessment capabilities based on ISUOG practice guideline. I'm going to be a game changer for ultrasound sector to redefine scanners workflow with one simple touch and free up doctors to spend more time with patients. Being immune to variable results from different operators, I produce precise and consistent evidence, assist with making concrete conclusions, and improve confidence of clinicians at all levels. From enhancing preventive maternal care to leading to better patient outcomes, AIX notepads. We believe innovation initiates change. As fetus, let the real transformation happen.
This is a rare case which is using the scanning to show you what is the time exactly when you do all these 16 planes using the S fetus form. The counter on the upper right hand side showing the timing of this scan. As you can see, while the doctor is scanning, the section on the left side is already marked with in gray and with a check mark, which means already the section is taken. And the indicator in the below in the lower left hand side showing the gray or yellow or green, which show you the accuracy of the taken plane. And if you are the plane is not in the green section, you try when the doctor try to scan a little bit more precisely, it comes into the green area, and then the section will replace the higher score will replace the lower score one before we can confirm the plane and accept it to be in the report. You can see the section is changing down. Whenever the machine picks the requested plane, it will change. This is the amniotic fluid. By shooting the quad and then start to get each quadrant. Now we are already 2 minutes, almost all the section finished. And now by pressing the S fetus for amniotic fluid, you can quadrant together. After this, we confirming the sections to it becomes green. Whenever it's confirmed and accepted into the report, it will be green. Because if we are not satisfied 100%, we can remeasure or retake the view or something. Now all finished in 3 minutes and 2 seconds. Thank you. Thank you very much.
Thank you, Dr. Soha. It's very interesting.
Thank you.
Okay, any questions, Dr. Soha? Any questions? Okay, thank you very much, Dr. Soha. Now the session has come to its end. Thank you very much. You can move forward for other session. Thank you.
خلصت؟ بص course. smooth. First speaker will be Dr. Suhail bin Sani, will address us a rare case of massive fetal intracranial hemorrhage, place of ultrasonography in the diagnosis and management.
I can start. So, good afternoon, ladies and gentlemen. I have the pleasure to be in this international symposium. So let me briefly introduce myself. My name is Suhail bin Sani. I'm delighted to be here to talk you about rare case of massive fetal intracranial hemorrhage. And by the same occasion, I will thank my professors, especially Dr. Shadi, who is not here. Yes. So let me start by presenting Mrs. B.A., 34 years old, with no medical family or history family, no inbreeding in the couple, no history of trauma, bleeding disorders, or drug use. She is a gravida 2 para 2 with a previous cesarean section. The initial screening ultrasonography at the first and second trimester were normal. Maternal torch tests were negative. And she was referred to our fetal medicine center for suspected intracranial hemorrhage at 37 weeks of gestation. So, the clinical examination doesn't objective any particular examination, neither for the mother nor for the baby. And we have repeated the ultrasonography at 37 weeks of gestation that revealed an echoic process. Here, the hematoma with the start, and the frontoparietal cerebral hemisphere, the left cerebral hemisphere. There is the cerebral falls was displaced toward the right, and no anemia was observed based on the measurement of middle cerebral artery peak systolic velocity. Moreover, it was fetal single fetus concordant with its weeks as rich presentation. The amniotic fluid volume and the umbilical artery were normal. So this is a transthalamic section, like Dr. Nicholas yesterday talked about. The cephalic wall shows normal anatomic structure with septum lucidum, the two thalami, the posterior horn, and the midline shift. But at the left one, we remark as showed a significant deviation of the midline shift to the right, in the absence of usual structures. A neutral MRI of fetal brain was performed at 37.5 weeks, which confirmed the ultrasonographic findings. And hemorrhage was seen over the left process, the left frontoparietal cerebral hemisphere. The left cerebral hemisphere was collapsed, and a slight dilatation of the right ventricle, the third one, with mass effect with parenchymal hemorrhage. So let's remind what's a fetal intracranial hemorrhage. It has been reported with a prevalence of maximum 1 per 1,000 pregnancies. contribution of MRI brain. It's a valuable complement to the ultrasound and provides additional information that's useful in patient management. And it's such sensitive to detecting different aids of hemorrhage. We return to our case. The case was discussed multidisciplinary medical staff in our center. The precipitation of the delivery will not change the prognosis, and the cesarean delivery may not ameliorate the outcome of this infant with less severe lesions. Surely the couple was informed of the increased risk of stillbirth, neonatal death, and severe neurological prognosis, and our decision was an expectancy. But at 38 weeks and 2 days of gestation, an emergency cesarean section was indicated for non-reassuring fetal tracing. Apgar scores at birth was 7, then 8, and the neonate was pink, but had a weak muscle tone with a head-band sucking reflex. The biology, hemostasis test, and CMV DNA was negative. At day 5 of life, postnatal MRI examination confirmed the prenatal diagnosis by showing multiple bihemispherical extra-axial hematoma of different age, parencephalic multicystic leukomalacia, and no vascular malformation at MRI angiography. So, to summarize, in front of normal morphological ultrasound, normal hemostasis test, a negative PCR CMV, bleeding lesions and ischemic lesions, we decide to do the thrombophilia testing. The result was a protein C deficiency. Postnatal evolution was marked by a deterioration of the neurological state, leading to the death of the baby at 43 days of life. So, the most important is to know what is the future of pregnancy, ulterior pregnancy, to know the prognosis. So, the identification of genetic causes of intracranial hemorrhage can get the counseling process with regard to the risk of recurrence, in addition to providing relevant clinical data to the neonatologist for optimal management and prompt treatment of a newborn. So take-home messages for this fetal expensive intraparenchymal left frontoparietal lobes is that these classic lesions are heterogeneous, asymmetric, and progressive. Prenatal ultrasound has a good performance in detection of the cerebral injury. The screening is based on the importance of a transthalamic section with respecting the right anatomical marks and the interest of the ultrasound MRI confrontation in the investigation and the monitoring. It's a serious event. The assessment of thrombophilia must be part of the systematic etiological assessment of this pathology, which cannot be done prenatally, and labeling the etiology for the counseling. And thanks for your attention.
Thank you very much for being restricted to time. It's very impressive. Now, in extension to the morning sessions about scar pregnancy, Dr. Sahar Razgani is going to take us on a journey, telling us about the experience in the management of scar pregnancy.
Gail Sahar, a resident in obstetric and gynecology, practicing at Bizet Hospital under the responsibility of the head department, Dr. Masha Mourad. I am honored and glad to present for you today the SCAR pregnancy management methods and prognostic impact. First of all, the SCAR pregnancy is more common than previously thought. As we can see, the cesarean is continuous in growth, so the cesarean SCAR pregnancy is also increased, also the early placenta accreta. The SCAR pregnancy presents 1/1,800. It constitutes 6.1% of all ectopic pregnancy. The incidence is 1/800. Also, the article talking about placenta accreta and cesarean SCAR pregnancy are increased. So, what is the SCAR pregnancy? The SCAR pregnancy is defined as an ectopic pregnancy established on the myometer of a previous uterine SCAR. Like we can see, this is a segment cesarean SCAR, which is well-headed, and this one is uterine SCAR defect. We call it the diverticulum niche ismocele. The risk factor is the cesarean, but there is no correlation between the number of previous cesarean and the risk of pregnancy in the cesarean section SCAR. No relationship between the risk of pregnancy in the cesarean SCAR and the indication for cesarean section, the time between onset of pregnancy in the cesarean section SCAR and the previous cesarean section. But emergency cesarean section during labor gives more risk of poor healing. The symptomatology, it's mostly asymptomatic, but it can include abdominal pain and breathing. The diagnosis is ultrasound. It's uterine cavity empty, gestational sac at SCAR level, and residual myometrial thickness less than 3 mm. Also negative sliding organ sign. And in pulsed Doppler mode, we found a low resistant arterial flow, percentage index less than 1 systolic speed. But if it's elevated, it indicates a progressive pregnancy. The classification, there is especially 3 classifications, one published in 2000. Type 1 ontogenetic is developing toward the uterine cavity, and type 2 exogenic development toward the bladder. Also, there is classification published in 2017 on the SCAR at the level of a well-healed SCAR and in the niche at the level of a badly healed SCAR on ismocele defect. And finally, classification of 2018, the crossover sign. And we have placental accession abnormality. The crossover sign, less 2 or plus 2, it gives independent risk factor for placenta accreta, but the crossover sign, less 1, independent risk factor for placenta accreta and increta. The evolution. It gives placental assertion and adhesion anomaly, gives more placenta accreta, it gives damage to the bladder, uterine hemostatic hysterectomy with maternal morbidity and risk of hemorrhage. So, the management of a SCAR pregnancy, there is no consensus. It must be active, fast, and early. It depends on the classification, the age of pregnancy, the desire for fertility, the cardiac activity, the Doppler, and the age. The therapy, there is conservative treatment and radical treatment. For the conservative treatment, expectation, methotrexate therapy, vacuum curettage, hysteroscopy, and elective coagulation of vessels located at the implantation site, laparoscopy, laparotomy resection, and embolization uterine artery, especially when the Doppler abnormality high peak velocity or hemorrhage. And for the radical treatment, it's the hemostatic hysterectomy, like we can see. Donc, how to proceed? First of all, we look to the hemodynamic states. If it's not stable, we
we must do resection by laparotomy, uterine artery embolization, or hemostatic hysterectomy. But if it's stable, we look to the pregnancy dating. If it's less than 8 weeks or more than 8 weeks. First one, less than 8 weeks with plasma beta-HCG less than 5,000 and cardiac activity negative, we must give methotrexate in intramuscular. If the plasma HCG is less than 10,000 and the cardiac activity is positive, we give methotrexate, but this one intraamniotic. For both cases, we must do a clinical biology and ultrasound monitoring each 48 hours. If back persisting, we must do aspiration curettage as soon as plasma HCG less than 50 and the sprint of trophoblastic blood flow. If failure, we must consider it as pregnancy more than 8 weeks. For the pregnancy more than 8 weeks, we must specify the location of the implantation in the cesarean scar. If it's not deep, we must do hysteroscopy resection of the sac. If it's deep, we must do resection of the sac by the upper root and repair of the hysterectomy or embolization. The prevention, we must save the decidual layer, extramucosal suture, continuous and simple suture in overgest. The suture must include the deep level of the myometrial, closure of the visceral peritoneum. For our study, we concluded a retrospective study in the mother-child department of Bezert over a period of 3 years from 2019 to 2021 on 5 cases. The 5 cases, the age of our patient is between 29 and 40 years old, with the majority are more than 35 years old. All of them have already had a cesarean section. All the patients had at least 1 early abortion, 3 miscarriage, 2 voluntary termination of pregnancy, 1 curettage, 1 ectopic pregnancy. None of our patients had a history of polymyomectomy. In 3 of our patients, the pregnancy was manifested by metorrhagia, and 2 of them were asymptomatic. The diagnosis of scar pregnancy was made by ultrasound in all our patients. The treatment, all our patients received conservative medical treatment, 2 methotrexate therapy, 2 methotrexate therapy when the pregnancy is less than 8 weeks, 2 vacuum curettage when it's more than 8 weeks but on the scar, 1 hysteroscopy and elective coagulation of vessel located at the implantation site when it's in the niche. No patient had uterine artery embolization because of the Doppler with low peak velocity, and no hemostatic hysterectomy. Our patients were stable, hemodynamic stable. Post-therapy evolution, the average length of hospitalization was 30 days, with extremes ranging from 5 to 37 days. The mean time to plasma beta-HCG negativation was 43 days, with extreme ranging 15 to 117 days. Post-therapy complications were observed in only 1 patient, hematoma in front of the old scale. No case of uterine rupture, no hemorrhagic shock, no bladder breach. We had recourse to a blood product transfusion for 1 patient in our study population. So, the take-home message, the pregnancy on the scar is more and more frequent. The ultrasound, the diagnosis is made by ultrasound. The importance of classification to choose the most appropriate therapeutic modality and the best treatment modality combined out and multi-step treatment. Thank you for your attention.
Thank you. I think we will move to the next presentation.
University Hospital of Bizet in the north of Tunisia. And today I will present ultrasound factors predicting prostaglandin-induced labor success, validating a new echographic score. It's about a prospective study. We all know that the prostaglandin-induced labor, we all know the Bishop scoring system, which is based on 5 items, based on the clinical examination. So the Bishop scoring system is available. Sometimes the cervix is not reached. It's harmless, it's weak, it's not exact. We don't know that it's not exact. It's subjective. A new echographic score. So it's a great idea because it's available, it's easy, it's harmless, it's quick, it's accurate and objective and better tolerated by patients. So our material and methods, we have a prospective study, 13-month period, 75 parturient, prostaglandin-induced labor, 2 different operators working in double-blind clinical and ultrasound exam each. Our labor induction with the misoprostol patient. So we included in this study obstetric indication for labor induction, absence of active labor, singleton pregnancy with vertex presentation, and gestational age between 35 and 42 gestational week. We excluded from this study non-cephalic presentation, contraindications for vaginal delivery, previous cesarean section, uterine or uterine surgery, fetal distress, intrauterine growth retardation, and severe preeclampsia, and uterine fetal death. So we define the success by the patient reached active stage of labor less than 24 hours after the first dose of prostaglandin, and the failure by the non-entry into active phase 24 hours after the first dose of prostaglandin. The measurement technique was defined by la Haute Autorité de Santé. So we have criteria for measurement. The patient should be calm and in a gynecologic position. We have a probe lubricated and protected by a condom, and we should have a strict sagittal image with the internal and the external os of the cervix, and all the canal cervix should be seen. So the item score details. The first item is the cervix length. So how we get this length? We have the rock curve, and the P value was significant. So we define the cutoffs as 16 millimeter, and the higher cutoff is of 25 millimeter, and we applicate it for our patients, and we assign for each measurement 2 points if the cervix length is less than 16 millimeter, 1 point if the cervix length is between 16 and 25 millimeter, and 0 point if it's greater than 25 millimeters. The second item is the distance between the fetal presenting and the internal cervix os, and we measured this item by the protractor at the nearest degree. So we have the root curve for this item, and the p-value was not significant. So we defined cutoffs of this item by the positive predictive value and negative predictive value, and we had our cutoffs. If it's less than 4 millimeter, we applicate it on our patients, and if it's less than 4 millimeter, we assigned points find the cutoff at 110 degrees. And here is our score with the 3 items applied on our patients. We wrote the rock curve for our echographic score success, and we defined the cutoff of our score at 2. So if our score is greater than 2, we have success of labor induction, and if it's less than 2, we have more chance to have a failure. A second result, we applied the Kaplan-Meier function, and we found that score greater than 2 is predicting a labor induction shorter time outcome. So after that, we compared the ultrasound score, there is the Bishop score, and we found that the ultrasound score is more precious in predicting outcome success. And we don't forget the other, that the ultrasound is better than the clinical examination. Just here to say that each item was further study published the importance of each item, but no one before us had the idea to set a score, which is our strength of study. But our study had a small sample. So in the future, we will validate the score system with a larger sample and more categorized sample. Thank you. I'm honored to present my second presentation. It's entitled Ectopic Pregnancy, Ultrasound in the Service of Creation of New Therapeutic Score. So this study is done in the same department. So the aim of the study has been done by the aim to evaluate our Tunisian practice, diagnosis and management of ectopic pregnancy, and to make Tunisian recommendation by the Tunisian Society of Gynecology and Obstetrics. The study is descriptive, cross-sectional, retrospective, and multi-center. So all Tunisian departments of gynecology and obstetrics and university hospital are included in this study. We have 20 departments of gynecology and obstetrics. And we have taken the period of 1 year and decided to choose the year 2019, last period considered normal before the COVID-19 disease. We all know that during this period, the minor symptoms were neglected by patients. They consulted late with most of cases of ruptured tubal ectopic pregnancy, and there were big controversy about using methotrexate in COVID-19 patients to manage an ectopic pregnancy. And from the emergency registry, hospitalization files, anatomopathological reports, surgical reports, and statistical registers. Inclusion criteria was patients who were managed for tubal ectopic pregnancy during 2019, patients managed for persistent pregnancy and on location during the same period. The exclusion criteria were patients in whom the diagnosis of ectopic pregnancy was not retained. All exceptional locations were excluded: corneal, ovarian, abdominal scar, and cervical pregnancies. The non-inclusion criteria were observational and complete data records. So, our results. We had collected 2008 pregnancy and non-location files, in which we had 1,064 ectopic pregnancy treated. Here, both surgical and medical management are being used in all Tunisian departments. Our results, so for ectopic pregnancy, surgical management was done for 572 patients, and medical management for 492 patients. So it's a huge cohort of patients who had medical management, and it's the third study published with this number of cases after these two previous studies. So we define medical management success by the resolution of the disease without need for secondary surgery, and the medical management failure by an obligation to proceed to laparoscopy. So needing a second dose of methotrexate injection was not considered to be a medical treatment failure. So for this patient, we will base our score on the medical management. And we had two groups to compare after stratified sampling using the criteria of success and failure. Let's see, before the pre-existent didactic scoring system, the Fernandez score, it's based on 6 items. 2 of them are ultrasound items. If the score is less than 30, medical management with methotrexate is indicated with high success rates. The second score is L2 score, which is based on 4 items. 3 of them are ultrasound items. And if it's greater than or equal to 5, medical management with methotrexate is indicated with high success rates. So many recent studies discuss other predictive factors of success and failure. So we had the idea to have our new Tunisian didactic score. We consulted our data, epidemiology, and the clinical presentation. Age, parity, gesticity, the risk factor of ectopic pregnancy, contraception methods, and clinical presentation, and clinical examination data, and the biological data. And here, the progesterone level was not tested in all cases, 0%. And beta-HCG first level was tested in 100% of cases. Beta-HCG kinetics was tested in case of pregnancy and on location. We know that Learned Society has defined different cutoffs of ectopic pregnancy diagnosis. So our average in our study was 2,852. So we chose to test statistical p-value, 2,500 units of first level beta-HCG. Our validated, but also clinically relevant. So variables that showed collinearity were removed from this model. And we used odds ratio of the logistic regression model to calculate a predictive score for medical treatment success. So we elaborate this score with 7 items. And here this slide is to show how we used odds ratio of the logistic regression model to calculate a predictive score for medical treatment success. So our score is between 0 and 33, and our cutoff was 12. If the score is less or equal to 12, this is an indication for methotrexate, and if it's greater than 12, an indication for surgery. And here, this is all the patients who got the first surgery, and the score, and they all get a score greater than 12. So it's crystal clear that the ultrasound is a cornerstone in the diagnosis and management of ectopic pregnancy. So our strength points, this is a large sample with several parameters. Our weakness, our limits are retrospective study and only 1 year period. So further prospective study with a significant number of patients are needed to improve this score, and once this score is improved, it will be used in our hospitals. So I thank my dear physician-in-chief for allowing me to take all this data from different university hospitals, and thank you.
Good afternoon, respected professors and dear colleagues. My name is Olfa Shiri. I'm a resident in the Department of Gynecology and Obstetrics of Maternity and Neonatology Center of Tunis. Thank you for the opportunity to be able to present to you this afternoon the placental abnormalities from the first to the third trimester. It is a life-threatening complication whose risk increases in case of previous cesarean section or uterine scar. And according to the latest data published by the World Health Organization, the C-section rate is increasingly rising, as for example, it is ranging between 25 to 35% in Tunisia, and it is 45% and more in Egypt. In our department, during the last years, the C-section rate is increased to 62%. Likewise, for the placenta accreta spectrum disorder rate, it reached 0.46%. As you all recall, we can see the normal aspect of the placenta. So here we can see the line between the placenta and the myometrium with the homogeneous aspect of the placenta in the first trimester. And the growth of the placenta continues throughout the pregnancy until the third trimester. And we're going to proceed with the ultrasound diagnosis of placental adhesion abnormalities during the second and the third trimester. And we start with our first patient, who is a 20-year-old female, para 2, consultant for vaginal bleeding at 26 gestational weeks. The ultrasound findings, there was an ongoing pregnancy with a low-lying anterior placenta, as you can see here. It's not showing the pointer. Can see here, there is the bladder and a low-lying anterior placenta here, an absence of the hypoechoic line in these two ultrasound photos, placental lacunae, reduced myometrial thickness, and the presence of placental lacunae. So we suspected the presence of placenta accreta, and we performed an emergency C-section that confirmed our diagnosis. And we proceeded to an hysterectomy. Our second case is a 38-year-old patient with a history of a C-section delivery 3 times, consulted for contraction at 30 weeks. So the imaging here, the ultrasound, shows here's the bladder and also a low-lying placenta here. And the Doppler mode showed some bridging vessels here, in these images, and abnormal vascularization here. So we performed the diagnosis of placenta accreta was suspected, and we performed a C-section that confirmed the diagnosis, leading to hysterectomy. As for the third case, our patient had 2 previous C-sections, and she sought medical attention after having vaginal bleeding at 34 weeks. Here in the ultrasound, we found a low-lying anterior placenta near, in the previous cesarean scar, reduced myometrial thickness, a placental bulge here, an abnormal uterovesical hypervascularization, and abnormal placental hypervascularization. So we suspected placenta accreta, and we performed an emergent C-section that confirmed the diagnosis of placenta accreta. Here, shown at the photos in UR. So, as for the diagnosis of abnormally invasive placenta, there was a proposal for standardized items, such as the absence of hypoechoic line, the presence of placental lacunae, bladder wall interruption, reduced myometrial thickness, placental bulge, and focal exophytic mass. And should insist on doing both abdominal and vaginal exam in the full bladder. And in the Doppler ultrasound, we should look in for uterovesical hypervascularization, subplacental hypervascularization, bridging vessels, and feeding vessels of the lacunae. The latest published FIGO guidelines insisted on the ultrasound signs, especially placental lacunae Doppler and Doppler abnormalities with their respective sensitivity of 77.4% and 90.8%. And as you can see, the loss of hypoechoic space is not considered as the most sensitive sign. considering the severity of this complication, an ultrasound score was published lately in order to predict the diagnosis of placental accreta spectrum, in order to plan the future surgical management with a sensitivity of 100%, as if the score is below 5, there is no placental accreta spectrum disorder, and the score is reaching up to 20. So if it is higher than 50.50, we should plan surgical management for placenta previta afterward. And as for the 3D ultrasound, it's not conventional in diagnosis, and the role of MRI is still controversial. As you all should know, that placenta accreta and previta can occur in the first trimester. That's why we shouldn't miss it. And we proceed to our first case with a 35 years old with a history of a C-section consulting during the first trimester. The ultrasound findings were, as you can see here is in the bladder, a low-lying placenta with a reduced myometrial thickness and placental lacunae, placental bulge, and abnormal vascularization of the uterus-bladder interface. These are the same signs that we can find in the second and the third trimester. And she was diagnosed with a cesarean scar pregnancy. And we proceed to our next case, which is a 37 years old woman with a medical history of cesarean section at 32 gestational weeks. The first ultrasound was performed at 7 weeks. That showed a low-lying sac. As you can see, an empty cavity here. A low-lying sac, positive cardiac activity, an evolutive pregnancy with a cranial caudal length of 4 millimeter. And in the Doppler mode, you can see here the hypervascularization of the interface between the bladder the hypervascularization between the bladder and the myometrium with a reduced myometrial thickness here. And in the 3D, we can see clearly that the uterine cavity is empty and a low-lying sac below here. So the diagnosis of cesarean scar pregnancy was maintained. So in this video that shows the natural history of implantation cesarean scar section that starts with the implementation of the eggs, and then the presentation of the egg and the vascular remodeling. And here we can see the invasion of the myometrium. So the most alarming early ultrasound sign, it is discovered before 7 weeks, and it is a low implanted gestational sac with a sensitivity of 82.4%, with a sac that is located in the lower, as you can see here, in the lower half of the uterine cavity with an empty uterine cavity. And afterward, we need to differentiate between an on-the-scar pregnancy that could evolve toward a placenta accreta and in the niche pregnancy that can lead to bladder invasion and uterine rupture. In this video, we emphasize the importance of an early ultrasound in all women at risk. As you can see, after 7 weeks, the expansion into the uterine cavity continues, but the placenta stays in its first place. And from this on, we can fully understand the seriousness of cesarean scar pregnancy, as it is shown in our last case of a patient with a history of 2 C-sections that consulted at 9 weeks. The ultrasound showed an empty uterine cavity, a low-lying gestational sac with an active positive cardiac activity, and the Doppler mode here showed abnormal hypervascularization between the bladder and the myometrium with bridging vessels. The patient refused medical attention, but she came in afterward in hemodynamic shock due I want to emphasize the importance of ultrasound managers, cesarean sectors. As you can see, our patient is in the OR under general anesthesia, and we have the endovaginal probe with a guide in which we insert the needle to drain the amniotic fluid, as shown here in the video. And afterward, we inject the methotrexate into the set. Here we are injecting the methotrexate. So take-home message: if there is a history of cesarean section or uterine scar, think about placental assertion disorders. 2D ultrasound is the key screening examination from the first trimester onwards. And thank you for giving me this opportunity.
Now, coming to our last session in this room, and it is the last session in this medicine meeting, meeting. ونحن يعني نكون ختام خبيث. May I call upon Kate Gilad, Dr. Gilad Rodriguez. She is going to tell us about feasibility study in the assessment of congenital heart cardiovascular malformation by recent technique of heart fetal cardiac MRI. Welcome.
Share my research work and my experience in radiological diagnosis of cardiovascular malformation and participate in this valuable conference. My research work was about feasibility study and assessment of congenital cardiovascular malformation by recent technique of fetal cardiac MRI. I am Dr. Hind Jalaleddin, Program Director of Technology and Radiology Program in Jalala University and Lecturer of Radiology in Ain Shams University. To introduce my topic, you have to know first that fetal cardiovascular malformation is main cause or first cause of congenital disease and the first cause of infant mortality. 22 weeks and performing using all type of ultrasound mode, either 2D, Doppler, 3D, and M mode. Also, it has to assess the anatomy of all chambers, blood flow, cardiothoracic ratio, cardiac axis, and fetal heart rate. However, there is some limitation of fetal echo that's consuming time from 45 to 60 minutes and have technical skills, and it is a user dependent because it depends on experience of the doctor doing, and has a maternal fetal limitation in the form of maternal obesity, myoma, previous pelvic scar, or myoma in the scar, wound scar. Also, the fetal limitation was twins, oligo and polyhydramnios, fetal position and recalcification. So when introducing the advantage of fetal cardiac MRI over echocardiography, we have to know that it's covering the limitation of the maternal and fetal abnormality. Also, it has additional information to in cases of tumor, heart cardiac tumor and heart diverticity, as well as pericardial cyst and pericardial effusion. Also, it is the main study to detect extra cardiac abnormality. Our aim of work is to highlight the advantage of MRI over fetal cardiac cardiography and the assessment of fetal congenital cardiac abnormality. About our patients and methods, we have it was a cross-sectional study of 2 years duration. All the fetal cardiac MRI and postnatal echo was done in radiology department at Shams University. As regards fetal cardiology in Shams University in Cairo, University was a partial source of the cases. As regards the inclusion criteria of our pregnant women, it was all pregnant females suspected or diagnosed with fetal congenital heart disease by fetal echo during routine antenatal. About the exclusion criteria, it is the basic exclusion of MRI, either claustrophobic mother or mother with artificial implants or metallic therapy, cardiac valve replacement therapy, or any metallic implants. Our study was including 52 pregnant female with the FTI. As regard preparation, there was nothing special to be done to prepare a female for ultrasound or MRI. However, full history taken, and the procedure was explained specifically to the pregnant woman, and had opportunity to offer any question to answer because the mothers was feared for MRI and the imaging of what's happening inside this country. About obstetric ultrasound, we assess basic ultrasound with the fetal biometry, placental sign, amniotic fluid index, and abdominal situs. Also, we have including basic and detailed fetal echocardiography using B mode color or pulsed Doppler. As regard MRI, was performed between 24 to 39 week gestation with a mean age of 30 weeks. The cases was supine or lateral decubitus according to their comfortability of the mother. MRI was performed in 1.5 Tesla machine using phased array surface torso coil with no maternal or fetal sedation. Controlled maternal breathing was used with the average time taken in an MRI was 30 minutes. The imaging parameter, our sequences was taken in this fetal cardiac MRI, starting with a survey and shift into maternal plane in an axial, coronal, and sagittal using balanced turbo field echo, then shifted into fetal body planes, axial, sagittal, and coronal, and to access cardiac axis, as we will see in the next slide. Then shifted directly into cardiac imaging in a black blood, white blood, dynamic images, sequences. Each acquisition is based on an immediately previous acquisition to avoid misregistration caused by fetal movement, and there is additional images can be obtained if there is any suspicion of extracardiac lesion, like in for brain or body, if there is any extracardiac abnormality. This is a diagram to show you that's how we can take the cuts, starting with an axial localizer and then getting the half of the midline to getting the sagittal plane. From the sagittal plane, directing into aortic arch plane to getting the ideal coronal plane, from which we're cutting from apex to mid-mitral valve to get the long axis view of the heart, from which we can get a short axis view, and from this short axis view we can get a 4-chamber and 2-chamber for each side of the heart. As regard the real or dynamic sequences, we can see how it's different from systolic and anti-systolic view, either in long axis or in short axis view. So we can use it as a functional determination or quantitative images. As regard the images interpretation of the fetal echo, as we all know, how we can interpret fetal echo using a segmental approach, starting from the stomach view, 4-chamber view, 5-chamber view, outflow tract, aortic and pulmonary, and ending by 3-vessel view. Also, the additional sagittal view for aortic, ductal, and bicable view. As regard the imaging interpretation of the fetal cardiac MRI, we use a 10-step segmental approach, and they are modified approach to analyze the fetal cardiac MRI, starting with viscoatrial situs, cardiac position, size, and axis, and number of cardiac chambers and its relation to each other. Then ventricular looping, whatever it's D loop or M loop, use indication of inflow veins, either systemic or pulmonary inflow veins, outflow veins, size, position of aorta and pulmonary in relation to each other, if it's crossing or they are parallel together. Ventricular arterial concordance, we are passing with left ventricle, what is it getting out from its aorta, is it getting arch or not, it's getting the neck vessel or not. Also with the pulmonary, it's getting the arch which bifurcate its end in its distal end. And finally ended with the sideness of the aortic arch depending on the main bronchus above. Regarding our results, the mean age of maternal age was 30 years, maternal gestation age was 30.8 weeks, and gestation age of the delivery was average 37 weeks gestation. As regard fetal biometry and the molecular artery Doppler, these are the mean values of them. As regard fetal parameter, male gender was superior than female, presentation was mostly cephalic, amniotic fluid index 70-30% was normal, umbilical cord was 3-vessel view, and unfortunately 35% were the fetuses has experienced intrauterine fetal death. As regard the important history parameter, there are 42% of consanguinity, 30% of previous history of anomaly, and high-risk disease like gestational diabetes or hypertension in 11.5%. As regard the agreement between prenatal echo and fetal cardiac MRI results, there was a significant moderate agreement between both. There is both agreements, half of them are agreed together and half of them are not agreed together. As regard comparing a postnatal echo with a fetal MRI and fetal echo, we can show that fetal echo gave 86% agreement with postnatal. However, MRI was shooting. It's giving 95% agreement with the postnatal echo. As regard extracardiac anomaly detected by fetal MRI, we have 2 cases of congenital diaphragmatic hernia and 3 cases with omphalocele, 2 cases with developed CNS delayed development, and 2 cases of meningiomyelocele. 1 case of typhus, 2 cases of hydronephrosis, and 1 case of focal accreta of placenta, and 1 special case of ectopia cordis. Let's see the interesting cases. I'll shift to case number 1. It was 20 years old with history of consanguinity with no high-risk disease and previous anomaly in the form of hydronephrosis, fetus with hydronephrosis. The fetus was female, 24 weeks with breech presentation in normal placental and amniotic fluid index. Fetal echo diagnosis prenatal, giving that pericardial effusion, relatively hypoplastic right ventricle, solitary 3.4 millimeter VSD, and suspecting mitral regurg. As regard MRI, giving the experience of mild pericardial effusion, normal pulmonary venous drainage to left atrium, normal size both ventricle and 2 muscular. So MRI detect an additional muscular VSD, one in the mid and one in the apex. We are getting the postnatal echo, which is a gold standard, reveal the diagnosis of normal sized right ventricle, mild pericardial effusion, 2 muscular VSD, as the MRI said, and it was a case of resolving myocarditis. Second case, it was 20 years old with no history of consanguinity or high-risk disease. He has previously anomaly with a fetus with marked hydrocephalus with intrauterine fetal death. The baby was male, 24 weeks gestation with cephalic presentation and normal placenta in umbilical cord and amniotic fluid index. The record echocardiographic finding, it gave rise to cardiomegaly, picture of tetralogy of Fallot, severe tricuspid regurg, absent ductus venosus, with abnormal venous drainage between umbilical vein and azygous vein. As regard MRI finding, it gives a picture of cardiomegaly, moderate pericardial effusion, single large inlet VSD with common arterial trunk type 2 with side origin of hypoplastic pulmonary artery, prominent posterior azygous vein with compressed subdiaphragmatic umbilical vein draining into it. As regard, unfortunately, this baby died intrauterine, so we cannot know the exact diagnosis postnatal. As regard the third case, it is 38 years old with no consanguinity or high-risk disease and no previous history. The baby was female, 29 weeks gestation with normal amniotic fluid index with a single umbilical artery. As regard the echo, giving hypoplastic left side, giving the picture of hypoplastic left side syndrome, dilated main pulmonary artery, pulmonary regurg, tricuspid regurg, and aortic stenosis. As regard MRI finding, it's showing large membranous VSD, overriding hypoplastic aorta, atretic mitral valve, thickened tricuspid valve with normal pulmonary venous drainage into small left atrium. It's another pictures of MRI. It was impressive, really. As regard postnatal echo, it's confirming diagnosis of hypoplastic left heart syndrome with mitral valve atresia. So it's excluding echo diagnosis. It's not a hypoplastic left heart. Fourth case, it is 27 years old with a history of consanguinity and no. It is a primary gravida with no high-risk disease. The fetus was male with 37 weeks gestation. Cephalic presentation with normal placenta and umbilical cord finding. As regard echo, giving a picture of a double outer right ventricle. So echo first. It was query case from the echocardiographer. It was a query from double outer right ventricle versus hypoplastic left ventricle, large VSD reaching 7 millimeter. It was also a query in the outflow tract, either it is interrupted aortic arch versus coarctation. So let's get it to the MRI to solve this problem. MRI shows hypoplastic left side, large VSD, hypoplastic aortic arch, interrupted arch at the level of left subclavian artery with normal pulmonary venous drainage. As regard postnatal finding, it gives confirming the diagnosis of MRI. It is a hypoplastic heart syndrome with type B interrupted aortic arch. The last two cases was a special case. Unfortunately, both are died intrauterine, but case 5 is 24 years primary gravida within in vitro fertilization. Fetal echo revealed mesocardia with ectopia cordis. Cardiac MRI revealed associated diaphragmatic hernia, anterior chest wall defects, liver herniation through omphalocele, positional ectopia cordis of just left ventricular apex, small size main pulmonary artery with left pulmonary artery adjacency, and additional intra-atrial septal defect. The last case with this 34 years old female, echo revealed pulmonary hypoplasia, generalized hydrops with large, well-defined echogenic mass, getting out from the left ventricle with secondary tachyarrhythmia. So it was query either fibroma or rhabdomyoma. MRI solving this issue and diagnosis of detailed mass size, origin with signal intensity and component and septation inside, diagnosis of rhabdomyoma with residual mitral valve size with bilateral hydrocele. So when we are comparing our result with previously published results, our results getting the important information, MRI giving the important information to the echocardiography in 61%, in comparison to Zhu, Ital giving the additional information to just 18%. Maybe it's from our selection or inclusion criteria we are dealing with, so it's giving the higher rates than other studies. As regard comparing fetal MRI with postnatal echo, our study giving a significant agreement between, however, Tadras de Sousa Ital giving a full agreement between both modalities. And regarding accuracy of fetal MRI versus prenatal echo, our study getting the fetal MRI was higher in accuracy than fetal echo, which is going with Dong et al., which has the same result that the fetal MRI is better as routine obstetric ultrasound in detection of accuracy of cardiovascular malformation. And to conclude our research, is MRI imaging as adjuvants to fetal echocardiography may provide valuable information that could add to the prenatal diagnosis and evaluation of cardiac and also extracardiac abnormality. And this research was published 1 month ago. And it's my honor to present this topic with you today. Thank you.
Will be a closing ceremony after the end of the last talk in the next, the whole week, and during